Thank you. And I hope that this is actually very informative to all of you. The beginning, we're going to introduce, the questions and answers with few slides that probably will help us to introduce the topic. And then later on, we're going to be answering some of your questions. Okay? John?
Yeah. All right. Next. Okay. So I'm John Rice. As Louis said, I'm the medical director of liver transplantation. And what I'm going to talk to you guys a little bit about is just about liver transplantation. Why do we do liver transplantation? And then a little bit about the hows and the way it works. And I think it's helpful for everybody to kind of understand a little bit about what we do. And it's always important, I think, as patients and family members of patients to understand what's going on and maybe some of the lingo that we're talking about, and at least understanding why something's happening to your body. And this is my attempt to help you kind of understand that, and then what we think about as a transplant program when we're seeing somebody for liver transplantation. I'll try not to be boring. I know Louis said it was going to be fun. I make no promises. But with that, next slide. It's like one of those old slide projector things. I got to keep saying next. All right, so I'm going to just have an outline of what we're going to talk about here. Just a definition of cirrhosis. People may not know what cirrhosis is, and we'll talk about that. What the complications that happen to people who have cirrhosis. Why liver transplantation? So why do we do liver transplantation? What are we doing when we evaluate? When we talk about the liver transplant evaluation, what are we doing? And then we'll talk about the wait list. Okay, and for people waiting for a wait list, what kind of donors are available. Next. All right, so what is cirrhosis? So cirrhosis is abundant fibrosis or scar tissue. Okay, so many of you have probably had stitches or had a surgery of some sort before, and when that heals up, you're left with a little band of fibrous tissue called a scar. Okay? So scarring is just your body's response to wound healing or injury healing, okay? And so for people who develop cirrhosis, they have a long-standing injury to the liver, typically over many years. Many people have no idea they have something wrong with their liver. Liver disease doesn't cause many symptoms, so they're unaware, but all along the liver is getting more and more scarred up. Eventually, the liver takes on a lumpy, bumpy appearance, which we call cirrhosis, okay? And you can have cirrhosis and still be completely asymptomatic, but once you have cirrhosis is where the risk of complications begin to develop. Next. So don't mind all the little busy words over there on the side there. But the complications of cirrhosis really fall mostly into three categories. There are other complications besides this, but the big ones are these three. The first one is the liver can start to fail. Okay, the liver is a vital organ. It has a lot of important functions, and it can stop doing those functions as well with cirrhosis. Second complication is called portal hypertension, or high blood pressure in the portal vein. Now, if you see up there in the top left corner of that picture, that big brown blob, that's the liver, okay? And you see a big blue vein going into it. It's called the portal vein, okay? That drains all of the blood from your intestines, your spleen, your lower esophagus, your stomach, okay? So it gets a lot of blood flow, and ordinarily it's under fairly low pressure. I mean, there's not a lot of driving force of that blood. As the liver gets scarred, though, that pressure begins to rise in that vein, and it causes some problems. The third risk is that cirrhosis is considered a precancerous condition, meaning there are certain cancers that are can develop in people with cirrhosis. That's not to say that everybody with cirrhosis develops liver cancer. In fact, the minority of people with cirrhosis develop liver cancer, but it is a risk for that. As I mentioned before, the liver is a vital organ. It has many functions. So it drains all the blood from your intestines, so everything that you eat makes a pit stop in the liver before it goes to the rest of the body where it's processed, stored, makes cholesterol, stuff like that. It removes toxins from the bloodstream, and then it protects against infections, particularly against all the bacteria that live in your intestines. You probably have heard that your intestines are laden with bacteria, and they are, and some of those bacteria can find their way into the bloodstream, and the liver's job is to clean those out. We can estimate how the liver works with blood work. So you may hear something about bilirubin, which is the substance your body makes, and if your liver gets sick, it can build up because the liver's not getting rid of it. It can cause a yellowing of the eyes and skin called jaundice. Liver also makes blood clotting factors that help keep your blood thick. So as the liver gets sick, those clotting factors decrease, and your blood becomes too thin. It's called an INR test. So you may hear us talk about bilirubin and INR, and we're talking about liver function at that point. And then this is one that really needs to stick in the back of your mind, and that's the MELD score. Okay, the MELD score is important. The MELD score takes the bilirubin and the INR, as well as your kidney function, and plugs it into an equation and spits out a number. Okay, it gives you a rough estimate of how well your liver is functioning, and we'll talk more about that as we go along, but it's very important to know MELD score. So as I mentioned, it's a numerical score that's spit out from the bilirubin, the INR, and the creatinine, which is a marker of kidney function, and particularly some people with liver problems can start to develop kidney problems as well. And then we also use the sodium concentration in the blood as part of the new way we calculate it. For pediatric patients, the weight for your age, so how much you weigh versus how much you should weigh at your age, is also incorporated, and that's called the PELD score. So for pediatrics, it's PELD. For adults, it's MELD. It runs from 6 or -6 in the PELD all the way to 40. And as you can see from this graph that I put up on the right, the risk of dying from liver disease is really strongly represented by the MELD score. So for people less than 15, MELD score less than 15, the risk of dying is quite low. For those over a 28, the risk is quite high. For people in between, it's sort of a gray area. Okay? So keep that MELD score in the back of your mind. Next slide. So portal hypertension, I talked about, is that high blood pressure in the big vein that feeds the liver, and it should be under very low pressure. So when the cirrhosis sets in, or extensive scarring, it basically starts to act like a dam. Okay, so that blood is coming in the same rate it was before, but now it's having a hard time getting through the liver, and pressure is starting to build up behind it. If you've ever seen a river that's been dammed or anything like that, you know the big lake forms behind it. It's the same kind of idea here. As a result of that, you get 3 complications. The first one is varicose veins start forming throughout the abdominal cavity. Okay? Remember that the liver drains all the blood from your esophagus, stomach, intestines, colon, your pancreas. All of those veins get under high pressure because the whole system is under high pressure. And you get varicose veins in there. And varicose veins are just big dilated veins. You can get fluid in the abdomen, and we call that ascites. That's the medical term for it. And you can get a confusional state that can set in. We call it encephalopathy. So if you ever heard the word encephalopathy, we're talking about confusion. Ascites is the fluid in the abdomen. So varices or varicose veins, they're really the only risk of them is bleeding. Okay, and if it bleeds, it can be quite severe. And if they bleed, it's almost always the esophagus. All right, the risk of bleeding is related to size. The bigger the veins, the more likely they are to bleed. And everyone who has cirrhosis should get periodic upper scopes, so upper endoscopy, where they make you sleepy and pass a camera down into the esophagus, stomach, first part of the small intestine, called an EGD. You may have heard that other term for it. Basically, the purpose of that is, A, to go down there and see if there are veins, and if there are veins, how big are they, and do we think they're likely to bleed? If we do think they're likely to bleed, there's a couple of treatments we can potentially offer to minimize the risk of bleeding. If they have bled before, it's very important to periodically get those looked at so we can try to prevent another bleed from happening. Fluid in the tummy. So as the pressure rises, the fluid will actually begin to leak out of the liver, and it fills the abdominal cavity. It can be quite uncomfortable. So basically carrying many pounds of extra weight of fluid, the abdomen gets very tight. It becomes hard to eat. Pants don't fit anymore, things like that. And it can get infected under certain circumstances. So the way we treat that, we ask you to try to decrease the salt in your diet. Okay, sodium is actually what your body uses to retain fluid. So you want to try to minimize the amount of salt so your body can't swallow as much. We may give you water pills, which help you urinate out that extra fluid. And for some folks, there's just nothing else that's working. We have to just drain it with a needle when it becomes uncomfortable. That's called a paracentesis. And this picture on the right is representative of that, where a small needle is inserted in the abdominal cavity and the fluid is drained out. The third complication of the portal hypertension is called encephalopathy or confusion. The liver is a detoxifying organ, meaning that its job is to get rid of toxins from the digestive process. And as the liver cirrhosis sets in and as portal hypertension sets in, some of those toxins can begin to find their way around the liver, or the blood goes to the liver and isn't properly processed, and these toxins build up and cause confusion. We call it encephalopathy. You know, it's interesting. I always try, when I talk about this with people, people always say, well, I'm always confused. It's not just, you know, I forgot where I put my checkbook today. It's really oftentimes more of a really a significant disorientation that would alarm your loved ones. Not knowing where you are, not knowing the date, doing things that you wouldn't ordinarily do, all the way to being completely comatose. So there's a couple treatments for it. Lactulose, if anyone has any experience with lactulose, you know it's universally detested. Its purpose is to bind those toxins and have them come out in the bowels. But unfortunately, it's a non-absorbable sugar, so it causes some pretty impressive GI distress. It also tastes apparently pretty horrendous. I've never tried it. I guess I probably should, but I never have tried it. And then we have a couple of antibiotics we use occasionally for people that are really struggling with the encephalopathy. Next. Last but not least, liver cancer or hepatocellular carcinoma. So cirrhosis is considered a precancerous condition, but that being said, most people with cirrhosis will not get liver cancer. But because it is a precancerous condition and because liver cancer is usually a pretty slow-growing and slow-spreading tumor, we will survey it, because if we can catch it early, we can intervene and potentially get rid of it, okay? So basically, everybody should be in a surveillance protocol, and that surveillance protocol can be as simple as ultrasounds all the way up to MRI scans. Sorry. Oh, it's all right. Next. There are a number of other complications, as I've mentioned before, and I don't want to leave anybody's other symptoms or complications out. And they are all, it's not the same for everybody, but very common things we hear is muscle cramping, muscle loss, trouble sleeping, fatigue, being cold all the time, very common in people who develop cirrhosis. All right. So I'm going to switch gears here and talk about transplantation and spend the last bit of my talk here talking about that. So it's a surgery. It's about 4 to 8 hours of time, depending on how it goes. It can be many more hours than that as well. So basically the whole liver that's sick, the cirrhotic liver, the cirrhosis liver is removed, and it's replaced with a healthy donor liver. And then Lou has to hook up all the plumbing. So there's a vein, the portal vein has to be re-sewn together. The hepatic artery has to be sewn together, so there's an artery and a vein. There's a vein taking blood out of the liver called the hepatic veins, and then there's a bile duct which carries bile out of the liver. And all that plumbing has to be rehooked together. It's much more complicated than that, but I like to make it sound as simple as possible just to make Lou squirm over there. Okay, so who benefits from a liver transplant? Why, when you come to us, do we say, well, you might benefit from a liver transplant? Well, the first group of people are people who are at risk of dying from liver disease, okay? And we set that threshold at roughly a MELD of 15, okay? So once you get above a 15, the risk of the liver transplant starts to decrease compared to keeping your own liver. Okay, so that's usually a conversation we start to have with people at about a MELD of 15. I will say the caveat to that is they have to have limited prospects for recovery. So if somebody has a previously untreated condition that we can treat and their MELD score might drop, then that may change the scenario a little bit. But assuming that things aren't going to get any better from where they're at, and cirrhosis is usually an irreversible condition, then we start talking about transplant at a MELD of 15. People with uncontrollable complications, okay? So people who have ascites that we just can't control with water pills and they're getting it drained with a needle. That's not a good way to live. It's nutritionally depleting. It's uncomfortable. It's inconvenient. That's time to start talking about as well, regardless of the MELD score. Those who have kidney problems in particular, it's significant risk, and that's a relatively urgent indication for consideration of transplant. And then people who have the encephalopathy or terrible confusion despite our best efforts also would benefit from transplant. And then some people with liver tumors. Hepatocellular carcinoma is actually the #1 reason that people get transplanted in the United States at this point. And then certain other tumors, although that's relatively infrequent. So the transplant evaluation is the team approach. Okay, so there's a transplant surgeon that you meet, a hepatologist like myself, a transplant coordinator, transplant social worker. We've got Beth here is a transplant coordinator, and Ellen is our transplant social worker, a substance abuse counselor if needed, a dietitian, and then other specialists as needed. And basically, we're trying to answer 4 questions. The first one is this problem bad enough to warrant a liver transplant? I see people all the time in my clinics, and they have a liver problem, but it's not at the point where I would say, like, you really would benefit from a transplant, okay? So that's the first and most important question. Sometimes we get referred people, and I say, you know, you have a liver problem, but it's not the point that I would say a transplant's the right thing. The second question we're trying to answer, if we say the first one that yes, you would benefit, the second one is, can we expect somebody to survive the operation and live a nice, long, happy life afterwards? We want everybody that we transplant to have a chance to live many, many years after transplant, and we have people who are 20, 30 years out. okay? But going into that operation, we have to have a reasonable expectation that A, that somebody can survive, and B, that there's no other medical problems that are just as serious as the liver disease, which may mean even if you survive the operation, that, 2 years down the line, we've got something else that's just as bad popping up. So we refer to your cardiac disease. What are cardiac risk factors? Why? Because most people in the United States actually die from heart disease. It's already at risk for strokes, heart attacks during the operation. Cancer, second leading cause of death in the United States, and there are age-appropriate screening recommendations made, meaning that people above a certain age should be getting mammograms, colonoscopies, pap and pelvic exams for women, and so on and so forth. If people have had cancer before, we have to have a reasonable expectation that it's not going to be a problem after transplant. And then I put the term functional status. That means, are you able to walk okay on your own? What's your prospects of being able to get up and moving after transplant and be able to get out of the hospital? Because that's what we want for everybody, right? We don't want people to have to go to the nursing home and not get out. We want people who can get back on their feet and get back to a normal quality of life afterwards. Third thing we ask is what we call psychosocial assessment, and basically we're trying to make sure that people can take care of a liver transplant. People who get a liver transplant have to take medications religiously to help prevent rejection of the liver. They have to adhere to all our medical recommendations, get blood draws, come to the doctor. Sometimes somebody might call and say, we need you to come into the hospital. People have to be willing to do that, or it just doesn't go as well as it could. And we might lose the liver, and that's not something we want. And then we always want to make sure you have the support to help you take care of the liver transplant, help you through that process and get back on your feet. And the last question we ask, and most importantly, is, do you want a liver transplant? Our job is to educate you about a liver disease and tell you what we think is in your best interest. At the end of the day, though, we're going to ask for your permission to do every step in the process after we feel like we've given you as much informed consent as we possibly can. Next. All right. So once that's all done, you go to the selection committee, which is a multidisciplinary committee, i.e. not one person. So no one person makes any decisions in regards to transplant selection. And all the stuff we've talked about is reviewed, all the testing, all the consultations and whatnot. And then we make a decision and we say yes. We say yes, we place you on the wait list. If we defer you, it means we need to get a little bit more information about a particular problem, and then we'll bring you back again. And if we do say no, and occasionally we do say no, we are one transplant program amongst many, and there are other options in the region that people can also look at. All right, so you're on the wait list. All right, so that's full of people waiting for transplant, the list of people. It's a fluid list. So some people talk about, time and things like that. Time doesn't really matter, okay? And it all depends on how sick you are and what your blood type is, okay? It's a fluid list, and then I send that people are being moved up and down all the time, and new people are being added, and old people are being removed. So where you stand on the list one day might not be the same place you're at 6 hours from now, okay? And again, all that matters is the MELD score, that score we talked about, 6 to 40, and the blood type. Okay, and there are 4 blood types, O, A, B, and AB. And here we go again. And we do have to match by blood type. So O is the most common blood type, A the next most common, B a little less common, and AB is relatively uncommon. So this is a chart on the right about our average MELD score for transplant based on blood type. The bottom line is the longer the wait list, the higher the MELD scores at transplant. Unfortunately, what that means you're sicker at transplant. So when you're getting into the MELD of the 30s, people are usually pretty sick, okay, having a tough time. It's a tougher recovery. Your lower MELD score at transplant, the easier it is to get back on your feet afterwards. And unfortunately, the really downside to it is there is an increased risk of dying on the transplant waiting list, okay? We do everything we can to try to keep people through to the finish line, but as they say, the waiting is the hardest part, and I think when liver transplant, that is the hardest part, is the waiting. Next. So that kind of brings us to our topic tonight. I kind of gave you my best intro as I could here, but so this goes into donor types. And when you come in, you're going to get a lot of information in your evaluation, and some of that stuff's going to blow right over your head because we're giving you so much information. It's an emotional time. There's people shuttling in and out, so it's hard to get all what you need to know. But for all practical purposes, there's 3 types of donors, okay? There's 2 types of deceased donors, and then there's live donors. So deceased donors are more common, okay? They are matched by blood type, and they are dependent on the MELD score. So that MELD score, when it comes to liver allocation, meaning how do I get a liver transplant for a deceased donor, that MELD score and your blood type are the two deciding factors. All right, and in that group of deceased donors, there's two types of donors, brain death and circulatory death, and I'll talk a little bit about that. On the other side of the coin here is live donor, and live donor is done relatively uncommonly compared to deceased donor. We match by blood type again. Usually for an adult to adult, it's a right lobe donation, although from adult to pediatrics, it can be a left or a left lateral lobe depending on the size of the child. It's not dependent on the MELD score. Okay, so that's the really key thing to remember about the live donors. It's not dependent on the MELD score. If somebody has an appropriate live donor, the transplant just gets scheduled. Okay, next. Going back to the deceased donors, I mentioned there's two different types. One is called brain death or standard criteria. Basically, what that happens in that case is that the blood has been circulating in the liver all the way to the point that it's removed for transplant. So the liver is getting fresh blood and oxygen all the way to the point of transplant. Of the deceased donors, it's the highest quality, depending on the donor, but it is the highest quality in general. Everybody's on that wait list. So if someone's on the wait list, everybody's on the standard criteria wait list. These are competitive transplants, though, okay, because they're of highest quality. They have the highest MELD scores of transplant. And some of you may not be familiar with the Share 35 program. Is important to know about, meaning that in our region, which is Minnesota, Wisconsin, and Northern Illinois, including Chicago, if anyone has a MELD score of 35 or higher in our region and a liver becomes available, that person will get first offer at it. Okay, so even if a liver becomes available at UW Hospital and there's somebody in Chicago with a 35 or higher in that blood type, that offer will go to them first. The second type of deceased donor is circulatory death, where somebody's had their heart stopped until at the time of the organ donation. So there is a small amount of time between the heart stops and the patient and the liver is removed where the liver is not getting blood. The procurement team goes as fast as they can to get the liver out, but there is a period of time where it's not getting blood. And there's a higher risk of complications because of that. The two big ones are the liver can take a long time to wake up, and sometimes not work at all, and need to be retransplanted. The bigger risk, though, is there's a risk of long-term damage to the bile ducts, which is the plumbing of the liver. And if that happens, it's we're just in the mood lighting here, apparently. Most people will have to be retransplanted at some point. Everyone decides yes or no, and people can make as many different changes as they want to that. So you can say yes today, no tomorrow, yes on Friday, and we'll go with whatever you said last, as long as we agree to do it. There are certain people we don't think it's a good idea. And the advantages to that is a smaller wait list. Okay, so people say yes or no, so not everybody's on that wait list. And there's a little bit lower MELD scores of transplant for people who get a DCD. Next. Let's hit this button. All right, so live donor. And this is where live donors has its advantages, because it really has the advantages of both the standard criteria donor and, in a sense, the DCD, in that you get a very high quality transplant. So we know the liver is of high quality, and you don't have to wait for it. Okay, so it gives you kind of the best of both worlds. The outcomes for live donor transplant are comparable to the highest quality brain dead donation or standard criteria donation. So that's the advantage. What's the disadvantages? Well, there's donor risk. Okay, it is an operation somebody's undergoing electively, and there is a small amount of risk associated with that procedure. Okay, and we'll talk a little about that in terms of what that means for us as a transplant program. There are some increased risks of some mild complications after transplant and live donor that you wouldn't necessarily see in a full liver deceased donor, but generally those are mild and usually fairly easily treatable and don't affect the long-term effect of the transplant. So I'll talk about donor safety. I mentioned the donor risk is really the downside to the live donor liver transplant. So it's important for anybody to remember, whether you're a recipient or a potential donor or a family member of a potential recipient or donor, that donor safety is actually the paramount of importance for UW live donor liver transplant program. Meaning that donor safety takes precedence over everything else that happens in regards to the process. So therefore, all potential donors have to be extensively screened and counseled. Okay, so part of the process of evaluating a live donor is, number one, assessing their overall physical and psychological health. Bottom line is we don't want any surprises if we can avoid it. Okay, got to make sure somebody's fit to undergo this and to recover from it. We need to screen them for pre-existing liver problems. Some liver diseases run in families. We want to make sure we're not transplanting somebody who already has a liver problem or using somebody as a donor who already has a liver problem. A big one is liver anatomy and suitability for donation, okay? And that is a big part of the testing process. Everybody can be hooked up a little bit differently. The plumbing can be a little different. And it's obviously critically important before you go to the operating room that you know that you can successfully get the liver out and then hook all the parts back together. And so that's part of the process of what you go through is to make sure that we don't get in the middle of an operation and say this isn't going to work.
So it's not that simple.
I make it sound simple. For me, it's simple, but you're dying over there. Anyway, so then we review the financial implications of what this might mean for a donor in terms of recovery, what the recovery expectations are, and then both the short and long-term operative risks of being a donor, okay? Is of absolute critical importance that anybody who wants to be a live donor understands what they're getting themselves into, what it means for them, and what the risks are. We want people to go in with as eyes wide open as they possibly can. And then anybody who is obviously a live donor here, we are committed to caring for any short or long-term care for any donation-related complications. So hernia at the incision site, things like that, are things we're willing to commit to caring for lifelong. That went a lot longer than I had intended. But anyway, with that, are we going to Lou here? Okay. This one apparently is supposed to be more lighthearted.
This is a great introduction. So there's few things. You always want to be a surgeon. That's okay. No, talking seriously. You know, many of you probably are in need of a liver transplant, or someone that you love, you know, need a liver transplant. And the truth is that when you guys come for evaluation, it's an overwhelming experience because you get to know a lot of people, and you think that actually you're dying when you are being shown the numbers of what is the MELD score that you have to reach in order to be in the top of the transplant waiting list. And the truth of the matter is that that is something of great concern to my team. And we have actually extended our training, you know, to kind of overcome those obstacles and try to offer liver transplantation as an option for people that have a lower MELD score. And what I mean with that is donation after cardiac death. That's one option that, even though it might sound like it's a suboptimal, it is much better than dying on the waiting list. And the truth of the matter is that we have introduced few changes over the last 3 years that have allowed us to minimize all these potential complications associated with donation after cardiac death that we actually had in the past. For instance, that kind of dying off of the bile duct that John actually mentioned before, the incidence of that stricture in the bile duct was about 36% about 4 years ago. It's now down to 9%. So we have made a significant improvement in the way that we do transplant, and we continue innovating in order to actually improve that. The other thing that is acknowledged is that, well, if you have a MELD score of 15 or greater, you are a candidate for liver transplantation. But if you have a MELD score less than 15, you are not. And it's not the case. There are many of people that you know, or yourself, who actually have a MELD score of 15 and their quality of life is miserable. Some diseases, as a matter of fact, okay, are not being well represented by the MELD score. What I mean with that is that, you know, they get parked with a MELD score of 10, and then they feel miserable, quality of life is horrible, they cannot engage in any of the activities that they used to in the past, and yet they go to visit John again, you know, 6 months after, and the MELD score continue being 10, in spite that maybe they have been in the hospital 3 or 4 times, you know, with a lot of complications related to cirrhosis of the liver. So liver transplantation with a living donor offers the possibility for people to get transplanted sooner, okay, and allows them to get back in their track better. One of the things that happen is, and I don't know if you have thought about this, you know, when the disease gets worse and the MELD score escalates up to the 30s, 35, it's not only that life is miserable, but maybe you're going to the hospital every 2 weeks to be admitted, and probably your kidneys at that point are failing. So live donor liver transplantation is an option that allows to avoid the kidney to get to that point. And instead of actually now, for those people that have a very high MELD score, instead of now needing to get transplanted with a liver, sometimes we need to do a simultaneous liver-kidney transplant. So we're trying to actually reduce that MELD score. And I can tell you, there is nothing, I mean, we should be so proud of live in the state that we are, just because our organ procurement organization, which is, you know, the institution that allows, you know, and is in charge of educate recovering organs for us to transplant, is probably one of the highest, if not the highest performers in the country. But it's still then, it's not sufficient for us to do and to cover all the need of all the patients on the transplant waiting list. The other thing is that live donor not only offer the possibility of being transplanted early, but also allow someone else to get transplanted with a deceased donor. Because if you all of a sudden subtract yourself from the transplant waiting list, you are letting someone else that is probably on a higher need to be transplanted. And last but not least are organs that work immediately, because what happens is we recover half of the liver, and I will elaborate a little bit on that. We always talk about the half of the liver, which is not true, but we recover that half of the liver and we take it to the next room and we transplant it right away. And really that liver is working and making bile in probably less than an hour. So it's fabulous to see that from, you know, a dead organ to an organ full of life that can represent many years of hope for that individual. So I'm going to go over some of these why mathematics doesn't fit liver transplantation. Know that I was very bad in mathematics when I was in high school and college, but certainly the more I think about it, I think it's true. We talk about, can I have the next slide, please? We talk about half a liver, so a half plus a half is equal to one liver. And that's not true. The truth is that the right lobe, which we think is a half of the liver, is really 5/8 of the liver, and the other 3/8 is represented by the left lobe. And that's probably the reason why more often than not, we can use the right lobe to transplant an adult to an adult. Because if there is no sufficient liver in order to guarantee that the donor have enough liver for them to regenerate that liver, and we will talk about that in a minute, and then for the recipient that is incredibly sick, right, receive a liver that can immediately function and provide and cover the need for that individual without having to be depending on the regeneration of the liver. So it is interesting. The liver have I think it was made to be split in a way. You know, it have a dual circulation. If you look at the portal vein, which is the structure that John was mentioning, it divides in left and right. The artery divides in left and right. The bile duct do the same. And the hepatic veins, they don't, but we make it fit. Okay? So we can actually divide the liver, and the truth is that when we split the livers, we never clamp the vessels. We actually cut the parenchyma, allowing the liver to continue doing what it needs to do, and it's only until the very end of the procedure that we actually divide the vessels and then flush the liver and bring it to the next room to get transplanted. Next slide. The liver is a mysterious organ. It's what we call the starfish. You know, you got an arm on the starfish, and then you wait long enough, and you know, the arm grows again. The same thing happens to the liver. So we're cutting a 5/8 of the liver, okay? And if you wait no more than 3 months, you have a full liver. The liver regenerates back exactly to the same size that it was. There is no other organ in the body that can do that, okay? The most incredible thing is, next slide, is do you actually transplant someone with a left lobe, but instead of waiting 3 months, you wait 5 months, you have a full liver again. So this liver can continue regenerating, and actually it's a self-limited regeneration. In other words, once it reaches the size that it needs to reach, you stop growing. It's not that you're going to feel, you know, the thing is moving out of your body. Right, Mike? Please. Say no to this. So it's incredible how you know, liver regenerate. Now, the other thing is, once you have been a liver donor, you cannot be a liver donor again. Okay? Don't get ideas. And the reason is because I'm taking the major structures that support the blood supply to that liver, and that portion doesn't grow back. What it grows back is the liver itself, but not the structures that are giving the blood supply to the liver. Okay? Next slide. So what is considered the ideal size? And that takes me to the Cinderella story, right? A large donor can donate to a small recipient because at that point, I have the option to take the left lobe or the right lobe. The truth is I have to be cognitive when I'm making that decision as to whether I'm leaving enough liver for the donor to proceed, and I am transplanting enough liver for the recipient so they can actually improve and get better. So it is easier to fit a large into a small. Sometimes the small to a large is not possible. And the reason for that is because, A, blood supply is limited, and 2, I have to make sure that the recipient have enough liver and the donor as well have a remnant, we call that remnant liver, that is sufficient enough for them to allow the regeneration. If I do not calculate correctly the volume, and we do this calculation several times, trust me, what happened is that we will leave the donor without enough liver, and that liver will struggle. And there is something that is called a more precise graft that actually goes for both the donor and the recipient. Next slide. So again, small donors will not fit a large recipient. Next slide. So the question is, what is the right fit? The truth is, we all in this room, good-looking people, right? We all look different. Our livers are different. The size of our livers are different. So this gentleman here that have a larger frame than mine, probably his liver is smaller than mine. We don't know until we do the CAT scan, right? So we actually allowed us to do that assessment rather than you assuming that a small will not fit a large person. I've been surprised, you know, doing CT scans, and I go, wow, you are made out of a liver. You know, it's like someone that have a very large liver that you go like, what happened to that liver that it grows so large? And the truth is, again, that liver will go back to normal size. It's just a matter of time, okay? So sometimes people say, can we split more than one donor and transplant someone with more than one liver? And yes, that can be done. We don't do it in this country, okay? That is only being done in Korea. This is romantic, Pam. We used to go out like that in high school. So, yeah, that is done in other countries, you know, that for instance, you have a donor, and that donor doesn't have sufficient liver volume to donate, but you have a second donor, so they actually take 2 livers and then transplant it into that individual. We're built a little bit larger than Koreans, so I think that option for us is few years away. But nevertheless, I'd like to actually give you that as a kind of a anecdote of what people do in other countries. Next. So, Ellen, do you have something to say?
I don't at this point. Was there something you wanted me to say?
Of course. I want you to talk about what is your role and what do you look into when you evaluate a potential donor.
Okay.
And how important is your opinion for us to decide whether to move forward or not?
Okay. So my role is predominantly to meet with recipients and their families to do what we call the psychosocial evaluation. And so what I'm looking at that point is what's going on in your life in terms of what would make you a good candidate for a liver transplant, and how would a transplant impact your life. We know from experience that it definitely impacts the family, and so we want to take a look at that and really talk to people about what this would be like for you if you were going to progress to have a liver transplant. Probably one of my biggest pieces that I'm looking at is support. There's a lot that goes into the transplant and the recovery, and we want to make sure that people have the support that they're going to need after a transplant. And if you have some gaps in support, then we want to talk about that and see how we can close those gaps. We're also looking at other things like what would the impact be on your job, what's your insurance situation, and all those sorts of things to make sure that if you do progress to the point of having a transplant, that we have you as prepared as we possibly can be from those areas. In terms of a donor, so there's several different people that meet with you when you're a donor coming in for your evaluation. We actually have a social worker, and the social worker would be looking at, again, what would the impact of donating have on your life and on your family, and do you have a situation that's going to lend itself well to being a donor. We also have you meet with an independent living donor advocate, and their responsibility is to look at whether the donor understands the risks of the donation, as well as sort of whether they're doing it voluntarily or not, and making sure that the person is well educated in terms of the risks, and if they want to continue to go forward, and if they're a match, that we have some confidence that they're going to be able to handle the donation. And then you also meet with a health psychologist, and their role is to kind of look at, sort of how are you put together sort of emotionally and psychologically that would lend yourself well to doing well being a donor. So we want to make sure that not only are we looking at the medical pieces, but also the emotional and psychological pieces to make sure that you would be able to cope with the things that come along with being a donor. So my position on the team, I certainly participate in the selection meeting that we talked about. And so my input is to talk about predominantly what is your support system and how will it hold up in terms of a liver transplant for a long-term support to you. We also talk a lot about, sort of if somebody has addiction issues, that's going to be a big issue for the social worker. We actually have an AODA counselor on our team that helps with that piece of the assessment. But we're looking at, because the transplant is, there's a lot of adjusting for you to do after a transplant, And if you already come with some sort of addiction issues, then I think there's a greater possibility of relapse for you because of the struggles that come with transplant afterwards. So part of our responsibility is to make sure that you have the resources that you need, that you can have long-term abstinence, and it can contribute to the success of your transplant. So my piece is to contribute all of those things in terms of what's going on in your life and how ready are you for the impact of transplant.
Thank you.
Yeah.
So we have Mike as a donor. Mike, how was your experience, and what do you have to share?
Yeah, so my sister-in-law and my brother got married back in about October of 2011, and she'd kind of always been sick, I guess. And so shortly after they got married, they started to do some testing on her, and they diagnosed her with primary sclerosing cholangitis, which is a very rare liver disease. They would be able to tell you how rare it is, but it is a very rare disease, and for women especially, like super rare. So this was something that was just, she had some extremely terrible luck, I guess, in certain ways, as far as that goes. I think she got diagnosed in probably 2014, somewhere in that time, maybe like 2013. It took her a while to get on the transplant list, and finally when she did, it was probably July of 2015, and she just came home and was like, I kind of posted on Facebook even, you know, I have information on being a living donor if anybody's interested. So when I went home next in July, because I live in Milwaukee, they're from Green Bay. The next time that I came home, I got that information, and I just wanted to find out more about it because, you know, educating yourself is the most important step. So I kind of looked at everything, and, you know, I was lucky enough to be in a position. I work for a nonprofit, and I've got, you know, decent time off. I've got opportunity. I had a really great opportunity, basically, to do this, and I was like, yeah, I want to do it. And so at that time, I kind of stepped forward and told them that. And there were some complications with insurance, and then she developed bile duct cancer at some point along the way, so they had to, you know, take care of that. And there's just a lot of things that kind of happened until I could finally get tested. But I did, it was October 23rd of 2015 I got tested. I'm sorry, October 29th of 2015 that I got tested. That was like the physical, like they did blood work, a lot of scans, CT scan, MRI, things like that, to see if my liver was large enough and able to actually do it would be a good match, and if my blood work was proper, and see if I had any other complications, things like that. So I learned an awful lot about myself at that point. So yeah, it was very interesting. They had me come back November 9th, so it was less than 2 weeks later for the second day, and that was more the psychological. I met with a social worker, I met with a dietitian to make sure that I was the proper fit for that. They definitely made sure I was doing things for the right reason, and I wasn't being coerced or anything like that. They wanted to make sure that I was financially able to do it and that I did have support, because basically after the surgery, I couldn't take care of myself. I needed somebody to help me at least with it. So that was November 9th. I think later the next week or later that week even, they ended up calling and saying, yeah, you're a match, you're good to go. When do you want the surgery done? We can do it I think it was the Tuesday before Thanksgiving, or we can do it the week later. I was like, Kathy, if it's okay with you, let's do it after Thanksgiving and actually enjoy the holiday. She's like, yeah, that's okay, we can do that. So we ended up doing the surgery December 2nd. And I arrived in Madison on December 1st, did the pre-screening, whatever it was, the paperwork for that day, and just more people coming at me and like making sure I was doing things for the right reason. And they also, throughout the process, the entire process, they kept saying, if you ever need a reason to back out, please let us know. It can be 10 minutes before the surgery. We don't care. Just let us know, and we'll, you know, take care of things, and don't worry about it. And it was very reassuring. And I mean, all the complications were laid out before me. I was able to make a really informed choice, and the whole process was just incredible. So I think it was the Tuesday morning on the 2nd or the Wednesday, whatever day that was. I ended up, I think I started surgery around 9, something like that, and I got out maybe like 6 or 8 at night, so it was a really long surgery. Obviously, I didn't care. I was out. And then Kathy was out for longer than that because she also went under a little bit later, but it was obviously more complicated for her. I was in the hospital for about a week. I mean, it was never, as far as recovery goes, it took a while, obviously. It takes a while to adapt and everything like that. It wasn't ever really super painful. It was like very, almost an ache. Not an ache, it was more than that, obviously. It's hard to move around and things like that. But I ended up, I like to tell this story because it's like shortly thereafter New Year's, so it was about a month in, I ended up having a root canal done on my tooth. And that was the most god-awful pain I've ever felt in my life. And I just had a surgery, like literally a month before, and I'm in dire pain because of this toothache, basically, and I had to get that done. So yeah, obviously it couldn't have been that bad. But yeah, it was a really good experience for me. I was at home with my family for a month, over a month actually. I ended up going back to Milwaukee shortly before February, and February 1st I was working again, albeit I have a desk job, so that made it easier for me. But very quick recovery as far as that goes. I was still feeling after effects and things like that, but it was a very good experience. And I don't view myself as being super healthy, or I tried to lead a healthy lifestyle, but it was something that really didn't affect me too much as far as that goes, and the recovery time was pretty good, I think, for, like I said, not being super healthy by any means. So yeah, it was just a really great experience, and like the whole staff down here just really took good care of me and Kathy as well. So. Is that what you were looking for? Okay. Making sure.